to get started in about 2 minutes, so if you want to get last-minute coffee, food, now's the time to do so. All right, good morning. I hope everybody had successful Hill Days yesterday. We have a number of events planned for you today, so let's hop right in. I want to welcome all of you to our Diversity, Equity, Inclusion, and Accessibility event. For those who don't know me, my name is Priscilla Rodriguez. I'm the Diversity, Inclusion, Advocacy Manager at the EveryLife Foundation for Rare Diseases. We have a number of exciting speakers here with us today who are going to present on a number of topics that relate to access and spending inequities in healthcare and treatment development, key achievements, and possibilities ahead. I want to start by giving a big thank you to our presenting sponsor, Alexion. And a thank you to all of our Rare Disease Week sponsors for making all of these events and this week possible. Thank you. So I'm just going to run through the agenda real quick. This is a 2-hour session. It will be split into 2 different sessions. So the first session will run from 10 to 10:55, and it will focus on access and utilization of healthcare services. That will be moderated by Natasha Bonham, who is to the right here. After that, we will have a 5-minute break from 10:55 to 11 a.m., and then we'll hop into our second session that will focus on cell and gene therapy disparities, development, approval, and access. So that will be from 11 to 12 p.m. And then we will take a break to head to lunch, and then that will be followed by our caucus briefing. All right, and with that, I would like to pass it over to Christina Hochul, our sponsor representative, who is also head of Strategic Alliance Development at Alexion.
All right, well, thank you all for joining us today. I'm so excited to see so many patients, advocates, all of us come together with policymakers, and especially about this inaugural event, which is like the first ever of EveryLife Foundation DEAI event on Capitol Hill. So I'm Christina Hochul. I'm head of Strategic Alliance Development at Alexion, AstraZeneca's Rare Disease Business Unit. And as you know, this is the most important week of the year for all of us in the rare disease community. And it's a chance for us really to come together with patients, with advocates, with industry, and even with policymakers to really talk about the greatest challenges and opportunities facing those who are impacted by rare disease. And so it's fitting that we're all coming together to talk about diversity, equity, inclusion, and accessibility. Because no matter how far we come in treating and curing these diseases, it won't really matter if patients don't have access to therapies. And so today we're going to talk about some of the rare disease community's accomplishments in improving access to these life-changing therapies. And more importantly, we're going to talk about the possibilities that lie ahead as we hear from our incredible moderators and panelists across these two great sessions today. So the first session is on access and utilization of healthcare services for rare disease patients. And in our discussion, I'm so excited to introduce our incredible moderator, Natasha Bohan. So she is the founder of the Expecting Health at the Genetic Alliance. She launched Expecting Health to bring together a range of partners to ensure patients' and families' perspectives are incorporated into policy and programming design and implementation. Her portfolio includes leading Babies First, the National Newborn Screening Resource Center, which reaches over 600,000 families and healthcare providers annually. Our second session will cover disparities in the development, approval, and access of cell and gene therapies. And I'm honored to introduce the moderator for this session, Kevin Wake. Kevin is the president of the Orel E. Owens Sickle Cell Disease Association of the Midwest in Kansas City, Kansas. He is actively involved in the Rare Disease Legislative Advocates and is the chairman of the University Health's Patient Family Advisory Council. Prior to his advocacy work, he worked in pharmaceutical sales for many years. So thank you all for joining us today, and I'll turn it over to the moderator.
Good morning, everyone. It really is such a great day to be here on Capitol Hill. I'm Natasha Bohan, and I'm really looking forward to moderating this session on access and utilization of healthcare services. It's really amazing that this, the 2024 Rare Disease Day and Rare Disease Week also marks the 15th anniversary of the EveryLife Foundation for Rare Diseases. I think that deserves a round of applause. And I've really appreciated the tagline that's been used this week in terms of unified, amplified, stronger than ever. I think just looking around this room and seeing how many people are here on a early, rainy DC morning, it can be really tough to get places, as I found out this morning, but it really shows just how unified and together we are in this week. For me, when I really reflect on that, I think about how we absolutely have seen over the past few days truly hundreds of advocates here in Washington really raising their voices, learning from each other, and really showing Washington and the world just the power that advocacy can have. And at the same time, I always like to say we've come a long way, but we also have a long way to go, and the status quo is not good enough for us. And so I'm really excited to have our speakers here today really shedding some light on that. I am going to go through and just introduce everyone so we can flow into the presentations one after the other. But first we have Amanda DeLeon, who is a board-certified licensed genetic counselor who specializes in cancer genetics in Orange County, California. In her current role, she is the Justice, Equity, Diversity, and Inclusion lead for her team and supports programs that increase access to genetic services for patients. In addition, she is very much involved in the genetic counseling professional community, including having led the Minority Genetics Professional Network's Latino Hispanic group, which, if you are not familiar with the Minority Genetics Professional Network, does amazing work to mentor people in that profession. And she's also supported the development of the Latin American Society of Genetic Counseling. Then we will have Michael Ward, who leads the Alliance for Aging Research regulatory and legislative efforts. In that role, he conducts direct advocacy and strategic planning for engagement with congressional offices, the White House, federal agencies, including FDA, CMS, and CDC. Michael serves as a convener for multiple coalitions that elevate the patient voice within the policy sphere of influence. And then we will also have William Romero, who is a queer disability advocate with fibrous dysplasia and obsessive compulsive disorder. Since being diagnosed as a young child, William has raised awareness around rare disease and disability with various experiences, speaking at conferences, organizing advocacy events, and interning at the Louisiana Governor's Office of Disability Affairs. So as you can see, we have quite the esteemed panel, and I hand it over to them.
All right, just making sure I got it set up okay. So just wanted to say that I'm excited to present this first topic in our DEI discussions focusing on access to genomic medicine for the Hispanic Latino communities. And I kind of want to start by setting the stage with a case example. So a 25-year-old Spanish-speaking female has 2 children, and her youngest son has a history of short stature, intellectual disability, heart defects, and self-injury. She lives with her children on a border town in Texas. She goes back and forth between Mexico and the US for care. And one of her son's doctors mentioned that a referral to genetics department is needed and scheduled her for an appointment. The patient's mother works 2 jobs and tried to reschedule her son's appointment when one of her jobs, a little long, yeah, a little shorter. Tried to reschedule her son's appointment when one of her jobs asked her to come in for an extra shift. But when she called the phone number, the directory was in English, and she didn't know how to reach. She tells herself she will call them to schedule an appointment the next day, but her daughter gets a stomach flu. She doesn't know what genetic testing is, so she pushes it off until the next time her son's doctor brings it up. So this case is not unusual. There are many patients out there who face barriers. So let us get further into this discussion and then come back to this case. So I wanted to start off by highlighting that when we talk about the Hispanic Latino communities, that we are talking about a very diverse, large population of the US. 20% or 60 million in the US identify as Hispanic or Latino. 13% or 40 million in the US speak Spanish as their primary language at home, and this population continues to grow. And just to say they're very diverse, so Hispanics are heterogeneous, include foreign-born and US citizens, monolingual English, monolingual Spanish speakers, multilingual speakers, and socioeconomically and educationally diverse subgroups. Immigrants are from many Spanish-speaking countries, each with unique cultural, political, religious, and linguistic characteristics. There's also differences in where these families choose to settle in the US. All this to say that it is really difficult to generalize for any one Hispanic Latino patient. So why is this background information important? Well, these unique characteristics that shape us are important when considering access to genomic medicine, and this is important. Being able to diagnose children in a timely manner is crucial for providing families the opportunities for disease-specific intervention, appropriate counseling about reoccurrence risks, access to additional resources in some cases, but also addressing some of the psychosocial challenges of the diagnostic odysseys that parents undergo. Genetic disorders affect around 6% of live births. 50% of patients with a rare disease never receive a diagnosis. Those who do receive a diagnosis may endure a slow, costly process to find an answer known as the diagnostic odyssey. This time between the provider's initial concern about a child's development through the time a diagnosis is made. And Hispanic Latinos are more likely than other groups to face barriers to important genetic services. And just in case people haven't heard of genetic counseling, genetic counselors are professionals who have specialized education in genetics and counseling to provide personalized support about one's genetic health. There are various specialty areas such as cancer, prenatal, cardiology, metabolic, neural, etc. And a typical appointment with a genetic counselor has the following components. There's contracting, information gathering, risk assessment, as the genetic counselor learns more about the reasons for the appointment. Personal, family history, and environmental exposures are further understood. There's information giving as the genetic counselor discusses next steps and genetic testing options, as well as psychosocial support. These conversations are usually quite in-depth and a very important piece of healthcare. And I just want to give a quick shout out to the work the genetic counseling community is doing to increase access. Current Medicare policy denies Medicare beneficiaries direct access to highly trained, board-certified genetic counselors, and limited access to genetic counseling services can result in increased wait times for testing and subsequent delays in diagnosis. So the goal of this act is just to enable genetic counselors to bill Medicare directly and be reimbursed for services delivered to Medicare beneficiaries. If we improve Medicare beneficiaries' access to genetic counselors, this could also improve care for non-Medicare patients. And right now there's a large support through many different organizations for this bill, and now just working to keep encouraging support. So let's talk about barriers to genomic medicine. So a big characteristic of the Hispanic Latino population that I want to start with is language. In fact, some research has found that language may even play a more important factor than racial ethnic concordance in determining healthcare behaviors and access. And so what happens when the provider does not speak Spanish? Interpreters are then used. The integration of interpreter services has helped to transform non-English speaking patients' experiences, leading to better overall communication, increased patient satisfaction with care, and improved processes and outcome of services. However, providers of patients may not use formal interpreter services. There might be more difficulties for interpreters to interpret more complex genetic terminology. And this is not including the written materials that can be complicated or not even created for all the same resources that are in English. Overall, when patients feel like there is disconnect or miscommunication, there is greater confusion, less satisfaction, and less impact of message the provider and patient is trying to get across. This can sometimes be called culture bumps, divergent expectations about behaviors when two people of different cultures interact, exacerbated by the language discordance. For example, one study found that patients might be uncertain about care they're receiving and the role of genetic counselors in their healthcare management team, since many Latin American countries don't have these providers. Genetic counseling is not a well-known term, even in this country, for example. So having a provider who speaks the same language as the patient makes a huge difference. One of the biggest ones is the relationship. The ability to build rapport and trust fosters the relationship and transmission of information. Thus, then allows for patients to feel empowered to utilize their healthcare services as well as adhere to the plan that their providers put forth for them. Perhaps when the provider communicates in Spanish, patients are less likely to feel they're being viewed as an outsider. Patients who perceive themselves as outsiders may not believe the information they receive is unique to them. Rather, they regard it as general information. Similarly, when providers view patients as ethnic, racial group instead of as individuals, they communicate with their patients differently, and the patients disclose less lifestyle and psychosocial information. By directly communicating in Spanish, genetic counselors may be better able to recognize, respond to, and elicit patients' individual characteristics, and thereby more effectively address barriers. And so while language is a large barrier, there are additional barriers and considerations to take into account. Structural discrimination can block patients from even getting in the door. Patients oftentimes might be seen at smaller community clinics where providers might not have the same resources to support rare disease community or even the knowledge to recognize a need for a referral. There's also a lack of knowledge by the patient themselves to know to advocate for this service. But even once a referral gets placed, there are many barriers that can pop up. Logistical concerns highlight the barriers such as insurance type or status. Majority of patients denied whole exome sequencing, an important diagnostic test, had public insurance. There are also those patients do not have any insurance. Financial cost. Genetic testing without insurance cover is not cheap, and that's not taking into account the cost of going to appointments and using multiple work days, for example. And then there's competing concerns. There is more pressing cancer diagnosis in a mother, or if a husband just lost his job. those issues might be more pressing at the moment than an appointment that the patient might not understand the purpose of. What if patients came across care at multiple healthcare systems? Patients might not be able to see the same doctor or even go to the same hospital, and with records across multiple sites, submitting records alongside genetic analysis may prove more difficult. And as acculturation increases, there are reports of fewer barriers, more perceived benefits, and more favorable attitude towards genetic testing. When I see Spanish-speaking patients, they oftentimes come in with their niece who is a nurse, their cousin who speaks English, or their daughter who is in college. They tell me having that resource during difficult conversations is so helpful so that they don't have to take this all in on their own. Another area I want to touch on is the research infrastructure. With many barriers to accessing genomic medicine, research has become a way to access testing and follow-up care, but not if the same barriers we discussed earlier are barriers to research as well. Many patients are reliant on providers to access research and for providers to advocate and continue to keep looking for research opportunities. So what does it look like for patients that are not getting access to research? It shows in the data. More than 90% of participants in large genomic studies have been of European genetic ancestry. There has been a huge push to include minority populations in human genetic studies, including the NIH All of Us research program, which plans to collect DNA and health data from 1 million people. Half of the genomic data from the All of Us study are from participants of non-European genetic ancestry. That's huge. The study has already identified nearly 4 million new variants that may be tied to genetic risk. They have worked with community leaders, local hospitals, and providers to push to get patients from diverse backgrounds, and I hope to continue to see studies implement similar processes. This is important because of the lack of diverse participants in genomics research means we can't apply findings from the research as broadly as some of the results we get back are classified as uncertain, as more info is needed before laboratories can classify them more confidently. So take-home message. I want to go back to that case that I mentioned, so of a mother with her son. So what are ways that we could have changed the story? Having navigators that can assist patients through the healthcare system, financial discussions, and logistics setup or appointment can help patients not get lost to follow-up. Having the option to do appointments via video, telephone, or at earlier or later times might give the mother more options to come in. Let's also support this patient's providers. Having education training for primary care providers, interpreters, and other individuals that support our diverse communities can help get info to patients so she feels informed in her decisions. For this patient, we need to get the mother in the door and then make sure we have a good plan for follow-up in case logistical concerns come up. Can we provide the plans to the patient in the preferred language? Can we do follow-up to see if patient has any additional questions after? For this patient, we are trying to help her navigate the inequities of the system she is in and get her the resources she needs. And so I have some of these additional take-home messages here, but that's where I end for right now. So I'll say thank you and take it on to the next speaker.
All right, well, good morning, everyone. It's great to see everyone in this beautiful room here in the Ken House office building. And thank you so much just for coming to DC. Your time is so valuable here. You know, your presence here is felt. I know I've just been following even yesterday in the last couple of days, seeing the pictures of this powerful room of advocates coming up here. It makes such a difference because Congress needs to hear from you. And so just thank you so much for taking time out of your lives to be here. And so today I'm talking a little bit about access challenges, including utilization management challenges that we all face, kind of no matter the setting, but also making some of those relations to rural healthcare settings. And I'm not sure if the team at Priscilla and others knew when I was asked, but I grew up in a rural community myself, a town of 1,000 people in Oklahoma, in southwestern Oklahoma. I actually had a classmate who rode a horse to school, if you can believe that. There was a pasture across from school, so and he knew them, so he could the horse could could have a good day while he was learning. So this is a topic that that strikes home for me. And so just to get a feeling for the room, I just wanted to ask, how many of you would kind of consider yourselves to be either living or from kind of a rural community? Okay, so we have probably about a third of the room that feels like that encapsulates their experience. And I think that at least, is the mic a little off? Okay. Oh, that one didn't go. Okay, sorry. All right, thank you so much, Annie. So in terms of, I think we all understand kind of the realities, especially if you have a difficult to treat condition, of driving past the hospital that is 10 miles away, 10 minutes away, and going to the hospital that's 75 minutes away or an hour and a half away in order to see the provider that you need or get the health care that you need. And so there really are unique challenges that kind of face rural settings. And so I'm just going to do a little level setting. I think a lot of you may already know or unfortunately may have experienced some of these access challenges in your own life or in a loved one's life. So the first one I'm just going to tee up is prior authorization, right? So this is where a provider has to receive sign-off from an insurer before therapy can be administered. So, you go to your doctor, they say that you need XYZ medication, and Aetna or whoever your insurer is has to say, okay, we're going to pay for our portion of that, and you can go ahead and it can be administered. Or the prescription can be fulfilled. And this does operate differently if you're in a doctor's office versus whether you're in an emergency room. So if you go to an ER, you're giving care without requiring approval in the front end. Unfortunately, the insurer can come back later and say that wasn't medically necessary. You didn't actually have to do that after the fact and refuse to pay the claim. And so that leaves the individual at high risk of bills that can be very high, especially in the ER, as well as it puts the hospital at risk if the patient is unable to pay. So I know in just talking to I used to work for a hospital association, and so just thinking about rural hospitals, they also are concerned about that financial exposure too, because if a patient is unable to pay, the hospital has to pay. They're kind of exposure for that. They have bad debt is what they call it, and rural hospitals operate on much thinner margins. Because when you think of hospitals in large cities, academic medical centers, they have they're super fancy, but a lot of rural hospitals don't have that same setup, and so even administrators in those hospital settings are concerned about bad debt, about having this money kind of clawed back. The second theme I want to talk about is step therapy. So you may have heard this also referred to as fail-first therapy, where a physician provides, says, you need to be on this medication, but and then the insurer comes back and says, you have to try and not have satisfactory results on other drugs first before you're eligible to actually get the one that your doctor prescribed, which is really, really frustrating when your doctor knows all the ins and outs of your experience, right? They know all your comorbidities, they know the individual implications of your life, they may know the challenges that you face day to day that make this particular medication a better fit for your circumstance. And then you have an insurer kind of come in and say, well, that's not, we think that you need to try these other things first because they're less expensive. And this is extremely problematic, especially in conditions where patients may experience a loss of function on a temporary or a permanent basis kind of as they're going through the steps. So if you're thinking about vision loss, for example, macular degeneration, if you're failing on something and then you lose vision, and that's something you can't get back in most cases. And so people are experiencing kind of irreversible harm due to step therapy. And the third is just narrowing the formularies. So is your prescriber not covering as many drugs, right? Is there a drug that they used to cover, but now they aren't because they think it's too expensive now? And this is actually a growing problem. You all may have experienced it, but we speak to the aging population, so we do a lot of work in Medicare, which is the aging and disabled populations. And so in the Medicare population, there's been an 8% reduction over the last 5 years in the in total number of drugs covered in the prescription drug plans in Medicare. There's been an 8% reduction over just the last 5 years alone. So insurers are really reducing kind of the number of drugs that they're covering. And so as a result of all these tools combined, beneficiaries are facing an increased risk of treatment delays or loss of coverage altogether. And additionally, if plans narrow access to certain medicines due to these dynamics, patients who, you may be stable on a given medication, you may lose access, you may be forced to switch to an alternative medicine that's not optimal for your circumstance, this non-medical switching that you may have heard of as well. And this is also challenging because a lot of times people just stay on the same plan because they don't want to lose access to the drug that you're on, even if something else may be less expensive, right? Another plan may be less expensive. You just aren't always sure whether it's going to be covered or not unless you really do a lot of the legwork and call and spend a lot of your time to figure that out ahead of time. And in Medicare, it's because the Centers for Medicare and Medicaid Services allows prescription drug plans in Medicare to switch a beneficiary's medication in order to save costs. And so this drive is because insurers are trying to save money. And it's really challenging when you're thinking about, even staff, even your doctors, your physicians, because if your insurer uses step therapy, and then your doctor's like, okay, my patient, John, they really need this drug, and so I'm going to go to the mat for them. I'm going to fight for them. And so I'm going to go appeal this decision. They or their staff may have to spend hours on the phone, just listening, trying to get through to someone, the insurer, and then actually going through the process of appealing the decision. And so when you think about a rural provider, they're already running at full capacity, right? They tend to be really long-running relationships, let's say, in these communities, right? It's like your primary care provider might be the same provider that was your parents' PCP, et cetera, and so I feel like there's often like a closer relationship in some circumstances, and there's also just clinician shortages in the rural settings, right? There's just not as many doctors to go around as that are needed because there may be less pay and so forth, and so rural providers are already running at full capacity, and they're having to face these utilization management challenges, and so as insurers try to protect their bottom lines, we've seen utilization management and step therapy typically been more of an issue in these what we'll call commercial plans, these employer-sponsored plans. There's also kind of a growing concern in how this may transfer over to Medicare, including the Medicare Advantage and Medicare prescription drug plans. Recently, insurers have become responsible for a lot larger percentage of a patient's drug cost, especially if a patient is in what they call the catastrophic phase, so they have high drug costs. So last year, insurers were responsible for 15% of those costs. That's 15. And next year, they'll be responsible for 60. So if you're thinking from an insurer's point of view, you're like, I'm responsible for a lot more of these costs. I need to figure out how to control them. And so we're really concerned that kind of these challenges that we've seen in plans elsewhere are going to be affecting older adults and people with disabilities that are on Medicare. And so what can be done? There's the first thing that has been a really strong bill that's receiving a lot of consideration right now is HR 2630 in the House, and in the Senate it's Bill 652, and that's the Safe Step Act. And this will create guardrails around the use of step therapy by ERISA plans, which are those employer-sponsored plans and other plans that are common to the private market. And then second, I think it's really important now to raise awareness about what's likely to happen in the Medicare program, because what the conversations that I've been having with CMS is that they are in a wait-and-see mode. They want to see the data. They want to see that this thing is already occurring before they do anything, which seems a little backward. You kind of want to prevent something. If you know something is a likely possibility, it's good to stop and put guardrails around that happening rather than being reactive. And so So raising awareness of this right now with your legislators is going to be really important, and encouraging them to engage with CMS to act proactively before people actually start experiencing harm. And so, we talked, although I'm talking about utilization management challenges today, there's often a hidden cost in rural areas, including access. There just needs to be broader access overall, and so it's important to protect telehealth flexibilities. There's additional telehealth flexibilities that have been put in place during COVID that are expiring later this year, and so that's going to be very important. And second is not necessarily just a Congress thing, it's often just working manufacturers. It's encouraging the use of hybrid clinical trials. So one of the things that we learned out of COVID is that some of these things that can be done that you often had to go in for, during some clinical trials, you had to go in every so often to have checkups. Some of that can be done remotely, right? So you may need to go in for initial tests and intake, but a lot of the check-in appointments can be done remotely. And so I just encourage you all kind of continue your advocacy not only here, but also in your own disease communities and with the manufacturers that are in your spaces to encourage more of these hybrid clinical trials that can lessen the burden, especially for individuals that live in communities where it may be difficult to get to kind of clinical trial sites that are often in cities and academic medical centers. So thank you so much. And I'll hand it off.
So hello, good morning everyone. It is so nice to speak in front of all of you. I'd first like to thank Priscilla and Courtney for allowing me this opportunity to talk about a subject that's very important to me, which is the intersection of LGBTQIA identities and rare disease. So I'm going to talk a little bit about my story from a patient perspective and hopefully shed light on this topic that I don't think we talk enough about. So this is my story of living different. So there's me. My name's William, and I'm a senior at Vanderbilt University. But long before I joined college, that was how most people knew me. A small little kid who sometimes acted a little bit different than others, but who genuinely just enjoyed being himself. And I always felt like I was different than other people, even before I was diagnosed with my rare disease. I knew that the way that I was acting, it didn't feel like I was like my peers. Later, I'd come to find out that that was because of my queer identity, but at this age, I didn't know what to make of it. I just knew that I was not like my next door neighbors or my best friends. I was the odd one out. And at the age of 4, I was playing soccer, which is hard to imagine now because I could not be further away from sports. And I started to have a little bit of a limp. And my father came and he picked me up off the court, and that's what started my medical journey. We initially went to some doctors in New Orleans and in Lafayette. I'm in Louisiana. And they misdiagnosed, they misunderstood, originally thought it was cancer, and then they thought it was fibrous dysplasia, but they thought that we should amputate my leg. So we were like, this is probably not the safest place for me to be. So I went to MD Anderson, and I met Dr. Lewis, who is my doctor to this day, since the age of 4, and she diagnosed me with fibrous dysplasia at 4 years old. Fibrous dysplasia is a benign bone disease that causes rare benign lesions in my bones, largely my femoral neck, but it's located all over. It mainly causes me pain and a few surgeries, but other than that, like most rare diseases, we push through. So until middle school, everything seemed fine. I didn't have a lot of issues. There was one point in elementary school where my parents were scared that I was gonna have to have surgery, and we had to prepare my first grade teacher for taking care of me. But none of that never materialized. And everything was really good until the 7th grade, at least on the outside. Internally, I didn't want to talk about my disease. I didn't want to acknowledge the fact that I walked with a limp. I liked to ignore the people when they called me a penguin or made fun of my walk or looked at me different. And this was made even worse when approaching middle school, whenever my queer identity was finally starting to materialize even more. And I was the weird kid, the nerd, you see the Harry Potter. And I hid behind my academics. School was the place, like many queer people, I found school and the achievements that I was able to get in school as like a way to like take on this identity that allows me to deflect from my disability and deflect from my queerness and deflect from myself. Just put over a facade and make everything seem okay. But in middle school, I had to have my first surgery. In the 7th grade, I had a little bit of a growth spurt, and my femoral neck went from looking like this to like this. So we had to go and we took my fibula and we inserted it into my femoral neck. And this was a very successful surgery. See my mom and my aunt. And everything was really going good, but it was different being in a wheelchair. It was an adjustment, but I appreciated it. Because it made me, one, not hurt as much whenever I was walking, but also it just gave me a lot of freedom. And that's why I included this basketball pic, because I feel like after this first surgery was the peak of a lot of my illnesses. Like I felt like I had the most freedom and I could have this joy in recovery. And so I remember playing basketball outside with my brother whenever I was in the wheelchair. And that's some of my favorite memories. And so I finally felt like maybe I could come to terms with this. But then I fell. 1 year post-op in the cafeteria of my middle school, I slipped, I fell, and I fractured my femoral neck. So that is my current leg. I had another surgery, and they had to implant a plate and screws, and I had to start my freshman year of high school in a wheelchair. And while the kids in middle school thought it was cool that I was in a wheelchair, we could pop wheelies, we could do all those fun things, or go, whenever I was on crutches, we'd do crutch races. That was some dangerous stuff, but we did it anyways. But Wheels replaced William in high school. Everyone would be like, William, or Wheels. And I tried to like play along with it, but it bothered me a lot. And I felt like I could no longer hide from my disability, and I could no longer hide from my rare disease. It was time for me to start accepting it. So after hiding for so long and trying to hide in the academics and the successes and behind the facade, I started to find the advocate within. And I talk about this as my first coming out journey. I came out with my rare disease. I finally talked about my fibrous dysplasia. I talked about my experiences, and I felt proud. One of the first times, it was in junior year of high school, I hosted a panel at school about disability and school life. And that was one of the first times that I stood before my peers, and I told them about my experience, and I shared my story just like I am today for the first time. So that very much empowered me to embrace that part of me. But there were still parts of me that were hiding. But it turns out that coming out with a disability and coming out with my fibrous dysplasia made it easier to come out with my queer identity. In the same way that I went around and I told my peers about my fibrous dysplasia or my rare disease, in my freshman year of college, it was finally time to do that with my queer identity. And I finally embraced who I was. The little boy who you saw in the first slides, I finally returned back to him. And I became the person who I know that he would want me to be. And so, I'm no longer hiding. But that doesn't mean that it isn't hard. Whether it's anti-drag legislation, or just general hatred towards our community or the gay community, it's been difficult. But I try to channel that difficulty, like all of you here today, because you're all our advocates, into advocacy, into doing something, into action, because that's why we're here. So last year, I created Miss Daisybility. So Daisy is my drag persona that combines both my queer and disability advocacy. I actually have a drag show next Sunday that I'm like prepping for right now. So that's exciting. And in a community where I always felt like these identities didn't mesh, Daisy fills that gap. When I'm Daisy and I'm performing, I perform a lot differently than other drag queens because of my physical limitations and my mobility. But that's what makes me unique, and that's what lets me share my story. So Daisy's kind of taken on this persona of her own, and instead of hiding behind a facade, hiding behind the academics and the success, now I created one that expresses me in the most genuine way. So, what does my story really have to do with everyone else here today? I think it's important that we create a space for queer people with rare diseases. It is often hard to find communities that are both accepting of a queer identity and a rare disease identity. For example, in the gay community, there's been many a times where I've gone on a date and I've shared my disease because it's something I'm passionate about and I'm proud of. And a lot of times that's met with disgust or denial, and it hurts. And it's been hard to find that rare disease community and that disability community within the queer community because there is such a stigma. And it's similarly in the rare disease community. Oftentimes in these very formalized spaces, it feels weird to express my queerness and to be my authentic self. And so I think it's important that when we look to the horizon and what's next for us, we look at our rare disease organizations and we ensure that we're providing space for queer people. Whether that's through making sure queer people are involved in your patient advocacy board, or just making sure to recognize that we exist. One way or another, creating this space is important. Similarly, cross-state healthcare access is very important. I was lucky enough with Dr. Lewis and with my family that people were accepting of my identity, who I needed their support. But for so many people in our community, that is not the case. And this is where cross-state healthcare access matters. Because for so many LGBTQ youth, their healthcare is immediately connected to this identity. And even if your rare disease may seem unconnected to your sexuality or your gender, it is important to have a doctor that sees you for who you are, because that's what doctors are for. So I think whenever I look at the Accelerating Kids Access to Care Act, I think this is one of the places where I could see that being particularly useful that we haven't talked about yet. So there's me at the Eras Tour because it is Taylor Swift season. But I would just like to thank you all for listening to my presentation, and most of all, feel free to contact me. I want to be a resource for everyone in this room, whether you're a part of the community or you know nothing about the community. I think it's important that we start these conversations, and I hope that this is the first of many. Thank you.
Wow, I feel that's all I can say. A really excellent panel. So we have a few questions and discussion points that I'll share with the panel. The first is for Amanda. Really thinking about, we know that minority populations are less likely to receive a referral and have so many struggles as you laid out. My family is from Haiti, and some of my earliest memories is actually translating for my grandmother because we could not find someone who spoke Haitian Creole. So we know there's that, which can feel like even you're a step behind in the first step, right? And so then we have issues like delays in referral and how that can meet. Can you speak a little bit about, what can be done to ensure that diverse communities have access and can really tap into those resources and treatments, frankly, that they need?
I think that's
You have to push it.
Good. Thank you. So I think that's a great question. So I would say that there's a couple different directions to try to tackle this. So one is with the advocates and people in front of us that are able to speak up and tell their providers, we need genetic services, we need providers and access to that type of testing and support. I think that is one piece that really can make a difference, is just having people that talk about it more. And then another one is having resources in place that help patients get along. So navigators, promotores, or community health educators. These are individuals that can help these patients navigate this without having to rely on a family member, a younger relative to help them figure things out as well. So I think having programs in place, having the infrastructure, like I'm always surprised at how expensive it is to get translation services for a lot of documents that we need. So having that support to be able to make that more easier is another piece. But I think it just starts from the provider and the patient side being vocal and saying that genetic services are necessary and needed can go a long way into making the hospitals and higher up recognizing how important it is.
Great, thank you. The next question is for Michael. How do you know of any initiatives aimed at connecting rural communities, rural care sites to research systems? You listed so many of the different barriers, but what is, leave us with something positive, right? Do you know of something that's happening?
Yeah, I think that's a great question. It's been a movement, right? It's taking time to really do that. But I think certainly coming off of COVID, and I kind of closed the presentation with it, is that I think so much of the effort right now really needs to be kind of focused on, especially as we're talking about the Hill, is on those telehealth flexibilities, because that has been such a key part of ensuring that access has been expanded in these communities, because although actually, and I'll say even before the pandemic, the telehealth flexibilities were actually primarily aimed at the rural settings, but rural settings are not the only underserved communities, right? Like you can be in the middle of the city and be in an underserved community, and so ensuring that those flexibilities continue to move forward is going to be extremely important. And then again, just I think that especially for kind of the populations where there's significant unmet need, there's a huge challenge in access to clinical trial sites, right? It's not only like small populations. It's like, is the trial site, is it a state away? Is it, is it more than an hour? Is it 3 hours? But you're willing to do whatever it takes to kind of be involved in that process. To the extent that we're able to make it to work both in the private and public side, to make sure that those partnerships are strong, to ensure that that we're able to use as many flexibilities as possible and take out as much additional effort that's needed to engage as possible. I think that's going to be really key. So I think there's so many challenges that have come out of the last couple of years, but in terms of clinical development, in terms of access, those are two things I think it's going to be really important for us all to keep pushing on.
Great, thank you. My next question is for William. First off, thank you so much for sharing your lived experience and taking us truly on that journey of discovering the advocate within. I really appreciate that. There are a number of different initiatives that are looking at how to be more inclusive. I think of a committee I'm on through the National Academies of Science, Engineering, and Medicine that's looking at, more inclusion, better inclusion opportunities. But from your perspective, whether it's an agency or organization, what can be done to really be more inclusive of diverse representation from the LGBTQ plus communities? I like to say communities because it's not just one.
Perfect. I think that's a very important question, and I kind of answered it towards the end of my presentation. And I think that's through making sure that we are represented physically in these spaces. This is not just about seeming to be inclusive or seeming to be diverse. There has to be actual representation, whether that's on committees, whether that's, as long as it has some sort of action component. We can't just have people representing different diversity groups just as an idea. We have to have actual patients with lived experiences on these boards with actual actionable actions that they can take. Because I think one of the problems that we're facing right now is in the spaces where we're finally getting some notice, we're only getting representation on the surface. And so it goes so much deeper than that. And I think part of it is making sure that as an organization, as an agency, you recognize the humility that you have to have in those spaces. Because the truth is, you don't know everything about every community. And that's normal, and that's fine. But being humble about it and asking for support, that's how real change takes place.
Great, thank you so much. Yes. I feel that many of us have probably been on committees where we're the one and only and have to represent every single thing under the sun, it feels like, and how not just unfair, but lacking that is. So I think your point really went to that. I'll go back to you, Amanda. We know that there is a real small percentage of Latino and Hispanic genetic counselors, even though, especially since 2020, many of the genetic counseling programs have had programs to try to expand reach, expand recruitment, but those numbers are still small. What impact does that have on the services that are available today?
Yeah, and I agree, it's quite small. So only about 3% of genetic counselors identify as Hispanic or Latino compared to the 20% of the population of the US. And so not having these numbers, that's where we see the research showing that discordance, maybe some miscommunication, maybe some barriers. I know that genetic counselors are trained to be able to overcome these barriers, to be able to build those relationships even if there is discordance, but we do see that there is a huge benefit to having concordant providers that speak the same language, identify in the same cultures, religions, beliefs. And so, like you had said, being able to have pipelines in place, talking to middle schoolers about genetic counseling, talking to community colleges where there are oftentimes minority students can help kind of bridge that number and hopefully start to create awareness. And then of course there are those financial barriers in place that maybe limit that graduate school, but there's a lot of kind of plans in place to hopefully start pushing that number a little bit closer to what the US population is.
Great, thank you. And my next question is back to Michael. Even here in DC, we often, where there are many medical schools and opportunities, we hear still there are people who may live a mile away who don't have access, right?
Right.
And then we also have issues around rural who don't have access.
Yeah.
Could you do a bit of a comparison in terms of the issues in rural, especially when it comes to utilization management and just what the differences are so we have a better sense of, where action should take place?
Yeah, I think to the point, Tasha's, the challenge comes back to lack of presence in the communities, lack of providers that are serving these communities, there's just fewer resources that are kind of readily available. And as we're talking about, and just because you live in an urban area, when I grew up 10 miles, it took me 10 minutes to drive. Today, it was 10 miles and it took me an hour to drive, right? And so these things are not absolute in terms of, and some of these distinctions that we talk about versus rural and urban, they are not mutually exclusive. And so I think in addressing some of these challenges, it's talking about additional providers, it's talking about additional outreach opportunities to the community. Are there clinics in the community that are reaching individuals that don't have regular sources of health care? and things like that. So it's really just bringing kind of bringing that robustness that we kind of see in areas that have more advantages, financially or otherwise, or in access, and bringing it to communities no matter kind of their geography.
Great, thank you. And with, I think, 15 seconds we have left, I'm still going to fit in William. I would love just to hear your kind of, some final words for this group that's been on the Hill and has been in DC for the past few days and still has a lot of work to do, some encouraging words.
I think that's great. The hardest part of my journey was coming to terms with my identity, which is something that's still ongoing. The fact that everyone's here, or you're tuning in on the live stream, you're already further than I was so many years ago. And so I'd just like us to take a moment to reflect, not just on what we're going to do, but be proud of what you've done. You're here, you're fighting, be proud of that. And I don't think we celebrate that enough.
Amazing. That's it. Thank you so much, everyone.
All right, let's give one more round of applause for these amazing panelists and moderator. Well done. So we are going to take a 5-minute break, and then we will return for session 2, so feel free to use this time as necessary. All right, we are going to begin the second session. So if you want to finish up what you're doing and grab your seats. I'm not sure. I'd have to check it, but if not, provide it. Yeah, I'm very visible on. Okay, yeah. Well, I'll chat with you after. All right, so we are going to begin session 2. Is going to focus on cell and gene therapy disparities, development, approval, and access. And with that, I will pass it to today's moderator, Kevin Wake.
Good morning, everyone. First of all, I just want to thank Priscilla and the EveryLife Foundation for having this really important DEIA presentation and session this morning. We touched on several important topics already, and so we are now going to transition to the second half of the session. As many of you guys are aware, the U.S. Food and Drug Administration approved 2 milestone treatments in December 23, and that was Casgevy and Lyfgenia. They represent the first cell-based gene therapies for the treatment of sickle cell disease in patients that are 12 years and older. The average lifetime medical costs associated with sickle cell disease can average over $1.7 million a year, or a lifetime. However, the list prices for these gene therapies that have been approved are reported to be between $2 and $3 million. The issues of affordability, access, are points of contention for the patients, the community, payers, and policymakers. More obstacles exist in addition to the initial cost of the gene therapies, which include patients needing to undergo chemotherapy, being hospitalized for 4 months for their immune system to recover, and travel. Those are just a few. Patients are further concerned by the fact that the gold standard treatment of hydroxyurea for sickle cell disease, which reduces the frequency of pain crisis and can prolong survival, which was approved by the FDA in '98, still remains unavailable to many patients today. So with that said, I'd like to introduce our speaker, Ashley Valentine. And I'm thrilled to be able to do that. Ashley was instrumental in me attending my first Rare Disease Week 6 years ago. And so Ashley has really, Ashley has been the one that has really helped me in sharing my voice and my story on the Hill and throughout our community to promote change for the sickle cell disease community. Ashley Valentine is the co-founder and president of Cells. She's a recognized leader in the sickle cell community. With a professional background as a policy research analyst for federal clients, including Medicaid, Medicare, and the CDC, Ashley's passionate advocacy is deeply rooted in her personal connection to sickle cell disease, driven by her brother, Marcus. Together, they have achieved significant milestones, such as leading the sickle cell disease community in its first ever ISA review, forming impactful coalitions to advocate for federal legislation, testifying at the FDA to emphasize the significance of drug development, as well as many other things. So with that said, I'd like to turn it over to Ashley, and her talk is titled Ensuring Access to Therapies, a Sickle Cell Disease Community Case Study.
Good morning. Okay, so I'm advancing from over there. All right. So as Kevin said, I'm Ashley Valentine. I'm all of those things, but I'm also Fran's daughter. Fran's right there, and Marcus's little sister. So what I hope to do today is take you through a little bit of a journey of how sickle cell disease arrived at these gene therapies, because oftentimes the voices of the patient isn't captured what's in mainstream, and so I'm hoping to give you a little bit of perspective of how we got here today. So Sickle Cell's mission is to elevate the voices of the sickle cell disease community to influence policymakers and promote change. Go. So here's our staff. So you'll see some of our staff members here today, and I'm so proud of our team that has grown, because the very first Rare Disease Week that Kevin's talking about, it was me and my dad running around, and Dad was complaining about his shoes not fitting well. Here's our board members, and if you bear with me, the slides, I'm going to be doing one of these the whole time. All right, so today we'll talk about sickle cell, the stigma associated with sickle cell disease. I'll give you a snapshot of some of the drug development and policy advancements, and then we'll arrive at the gene therapies. But first, I want to just tell you the inspiration for my talk today. So also during my first Rare Disease Week, I met someone that was really important. Her name is Jen, and Jen comes from the Batten disease community. Now, both of her children live 12 years of age, and at the time that we met Jen, her son Noah already was an angel, and her daughter Lane became an angel 1 month after Rare Disease Week. But when we met Jen, she was excited, and she was happy, and she was kind. And anytime we go into those congressional meetings, she'd tell her story, and you'd just see the pain behind her eyes, but she knew that she had to be at Rare Disease Week. And we just had so much fun, the three of us, Jen, my dad, and myself. And what I learned during those meetings is that Jen and her husband, Tracy, were fundamental in getting the very first clinical trials here for children with Batten disease that keeps the children alive. But in developing those clinical trials, the progression of their children's disease was too far to enroll in the clinical trials, yet the altruism and the duty to their community inspired them to keep going. And so I went home and I said to Marcus, I said, we can do this. I met someone from our district, she's from Downers Grove, and if her and her husband can do this, then we can do this. Sometimes we think we're just people and that our stories are just ourselves, but when we come together as a community, we have a lot in common, and the force to make change is so important. And so with that, I also want to just say thank you to the EveryLife Foundation and RDLA for giving us this venue and bringing us together so we can meet people like Jen and the Van Houten family. So let's get into sickle cell disease. So many of us know sickle cell disease as what it is. It's a heritable blood disorder. What that means is that most people with healthy red blood cells have circular red blood cells that are round and carry oxygen to every part of the body. With sickle cell disease, the blood cells are stiff and rigid, and they don't carry oxygen to the parts of the body. They also cause swelling and vascular damage. So what that means is that they block circulation. So if you block circulation to a piece of the body, it means that that piece of the body dies. So some of the complications of sickle cell disease are extreme pain. That's the hallmark complication. And there's also other major complications like stroke, organ damage, leg ulcers, heart failure, et cetera. The list goes on. So another angle of sickle cell disease is who it impacts. Sickle cell disease disproportionately impacts Black, African American, and the Hispanic population in the United States. And the reason for that is because sickle cell trait, the carriers for sickle cell disease, is an evolutionary response to malaria. So wherever there's malaria in the world, there's sickle cell disease, and that's how it manifests in the United States as well. So sickle cell in the US affects about 1 in every 365 Black and African American living here, as well as a growing population of Hispanic and Latinos living with sickle cell disease. However, the other races and populations aren't counted yet, so we actually don't have a clear understanding of who sickle cell impacts. The other part of sickle cell that comes with the disease is the stigma, the prejudice, and the discrimination because of the racial category that it impacts, and also because the disease itself is stigmatized. So looking at sickle cell from another angle, the case prevalence. So we compare sickle cell to cystic fibrosis because that's another single gene disorder, and we compare sickle cell to hemophilia because that's another blood disorder. So you'll see that sickle cell is 3 times and 4 times the prevalence of these other conditions, and worldwide, the difference is almost unmeasurable there. But if you look at the disparity here, you'll see that in the cystic fibrosis population, they receive 3.5 times more public funding than sickle cell disease, and almost 400 times more private funding for sickle cell disease. And if you look at the main racial demographics of who is impacted by CF, you'll start to understand why that disparity exists. You'll also notice that for the cystic fibrosis community, again, there's 1/3 of the population, they have 101 plus therapies approved. And for the hemophilia population, they have 28 or more. And so I don't want to discredit or take away from the severity of these other 2 conditions. We highlight these conditions to show the disparity. And for sickle cell, you see we have 6 treatments approved. I will say it is a low number, but for many of us, this is still massive because 5 years ago, we had 1 treatment. And so now we're at 6. So this is a win. Now looking at sickle cell from an economic burden standpoint, so we're looking at annually, an individual loses about $15,000 a year on income because of sickle cell. So that's missed work, that's loss on job advancement, missing out promotions because they can't be at work for sickle cell, because of their sickle cell. On average, annually, people with sickle cell miss about 7 weeks of work, and they spend about $1,300 a month on healthcare cost. Other items that aren't measured but are so impactful is that sickle cell causes difficulty with everyday care, everyday tasks like childcare, errands, house chores, the list goes on. Looking at economic burden on the family, it says that annually families spend about $30,000 to take care of an adult with sickle cell disease, so that's their caregivers. And then for children, it's about $10,000. And you can see that difference because it shows that as you get older, the disease progresses. And then some other non-medical costs that, again, are not measured are things like transportation, childcare, et cetera. And on the system, Kevin touched on this a little bit, we know that looking at claims data and the sorts, the system spends about $3 billion a year taking care of people with sickle cell disease. And this is an extraordinary number, still knowing that people are dying in their 30s and their 40s. And on average, the average cost annually for individuals with sickle cell disease as the system is $1.7 million for that one person. So these are just some of the costs looking at it from a system level, but if you look individually at the person. So my brother and I did a little fun game of figuring out how much we spent in the 1 month leading up to his hip replacement. And so Marcus, leading up to his hip replacement, had 15 doctor's appointments in that month. And we spent about $600 in co-pays for the doctor's appointments for that month leading up to the hip replacement. And the reason for that is every single part of his body had to get cleared for surgery. For a surgery this big, he had to get his brain cleared, his heart, his lungs, everything. Next, he spent about $500 a month for prescription co-pays. And by that July, the family already had hit their $10,000 max out-of-pocket copay for prescriptions. We also know that Marcus receives $720 each month from his Social Security. So just looking at these costs right here, you see that that's not enough. So it required the family support to ensure that he could still live and be happy. Some unmeasured costs for just the months of July is my dad ended up taking a layoff. He could have been fired, but he has a very good relationship with his union. So he accepted a layoff, so he missed a full 160 hours of work that month. The reason was it was more affordable for dad to accept a layoff to drive Marcus to these appointments than to try to use Uber or any of those other services. And then my mom, who had the good insurance, as we put it, the federal insurance, she had to use 30 hours of her FMLA unpaid leave in addition to her sick leave, prepping for this procedure. And then other costs, of course, are the flights that I was taking back and forth and the other financial support that I can offer for the family. But, this is just one story, and this is a common story because hip replacements are often common in the sickle cell disease community. And the hip replacement restored Marcus's dignity, and he was able to come to Rare Disease Week in 2019 and 2020. So what does this translate into data? Because a lot of us here understand that data is what really moves the needle. So when looking at people with sickle cell, in a survey conducted by Vertex, over 50% of the participants were unemployed due to sickle cell disease. It's hard to maintain a job when you're sick all the time or you have to go to the hospital. And then amongst some of the minority participants who were employed, they reported that they were missing about 9 to 10 hours of work in the week because of the sickle cell disease. And so we have other stats here about the absenteeism, the presenteeism, productivity loss, and what that means is absenteeism is you miss work. And as a result, this means you won't be chosen for those promotions, or you miss out on those opportunities to network, to know about in-office transfers or lateral moves. You miss out on those because you're at home taking care of that person with their condition. Another snapshot here is also looking at the participants who had pain crisis despite being on hydroxyurea, which for a very long time was the only approved therapy for sickle cell disease. And we can talk about that a little bit more later, but then it also shows that on average, participants had pain crises almost every 9 weeks, and a lot of these were treated at home. So that's just a little snapshot of what the sickle cell space looks like present day. And what I want to do is take us through this journey of stigma. And the reason why stigma is its own section is because sickle cell was discovered in 1910, and I'll show you some of this, but we didn't receive our first approval until 98, and we didn't receive our first major approvals until 2017, and gene therapy is here in 2023. So it took over a century, and the reason for that is stigma. So here we spoke with Tabitha, and she said, we asked her, what's one misconception about sickle cell disease? And she said that sickle cell disease is a Black disease. That's a huge misconception. I know people of Hispanic and Latina descent. I know people of Irish and English descent. And I know people of Middle Eastern descent who have sickle cell disease. It has nothing to do with skin color. I think people should know that. They need to learn that this disease is a genetic disorder, and that's it. So taking us through definition, so we pulled this from one of our advisory members, Dr. Generette, and the definition of stigmatization is the process of identifying an attribute of a person or a group and associating that attribute with a stereotype that negatively impacts or brands another in a way that is perceived as disgraceful by society. So we heard the previous panel talk a little bit about stigma. Now the other type of stigma is health-related stigma. And so health-related stigma refers to a form of devaluation, judgment, or social disqualification of individuals based on health-related conditions. So why I share both of these is because sickle cell suffers from both of this. So there's the stigma of who we are as a racial, ethnic demographic, but then there's also the stigma of having sickle cell disease. The disease diagnosis carries a stigma in itself. And a stat that I didn't put on here is that it's widely known that sickle cell is a horrible condition. However, many patients die from the stigma that contributes to a lack of access to healthcare almost faster than the disease. So what does this look like? In another survey that we did, we found that majority of patients with sickle cell believe that they were treated unfairly in certain hospital settings due to the race and the color of their skin. We also know that 60% of participants felt that the healthcare system treats generally people unfairly based on their racial and ethnic category. There's also a great deal of research that says providers are uncomfortable giving pain medication to people with sickle cell disease, and then there's that wide known misconception that people with darker skin have a higher pain tolerance, and that's just simply not true. So looking at, that's not true. So looking at a history of sickle cell disease. So sickle cell was first discovered in 1907 in a patient named Walter Clement Noel. So he's the first known person living with sickle cell disease, and he was diagnosed in Chicago in 1910 by James Herrick. And 1910 is when we say sickle cell was discovered because of that discovery. Now, another major piece of history here is that Linus Pauling is a world-renowned researcher that identified sickle cell being a single gene disorder, a single gene mutation. So he was able to identify the root cause of sickle cell disease. He also won a Nobel Prize for some of his other work, and his work is still used today in modern day research. Now, however, the same researcher published his thoughts about people with sickle cell trait, and it says here, I agree we should keep these carriers from marrying one another. I've advised, not entirely jokingly, that individuals should have tattooed on their foreheads symbols for defective genes they carry. He went on to later say, it might be better to tattoo the symbols in Braille on their abdomens. And this was written in 1959. So if we move ahead to a different story, this is the story of Margaret. So Margaret was the very first African-American flight attendant to be hired by a commercial airline. And there was a lot of contention about her being hired in this position. She was unmarried. She was of a different color that wasn't preferred at the time. And what was used by the airline to ultimately fire her was her disclosure of having sickle cell trait. So there was one study done that said potentially people with sickle cell trait flying could sickle. It was proven to be untrue, but that was enough to have her fired and lose her job. If we move on to modern day times, in 2019, there was an article published by the New York Times, and it was written that there are concerns about whether patients will take the new drugs regularly if they are prescribed. Many adults with sickle cell disease have subtle or overt brain damage, which can make it difficult for them to fully understand, plan, or adhere to treatments. So for those who don't know about sickle cell disease or understand, so this was published at the time when Oxbryta and Adakveo were approved. And those were some of the very first blockbuster treatments that we got. And this article was written and no one with sickle cell disease was interviewed. Not one patient advocacy organization was interviewed. And the doctors that were interviewed were not some of the doctors that we typically work with. And so they went ahead and published this stereotype that we are ill-informed, that we're dumb, that we're unaware. And the reason why we're not deserving of new drugs is because we wouldn't take them anyways. Another example of how the stigma has crept its way into modern day work here was during a 2023 ICER review on the gene therapies. So I'll talk a little bit more about what ICER is later, but the ICER review is an important piece of work because it influences some of the decision makers when it comes to building out formularies. So in working in this ICER review, one of the researchers referred to sickle cell people, I'll read his quote, they got the economics mostly right, but how they saw us came through in their writing. So it said sickle cell disease can affect nearly every organ system in the body, and severe sickle cell disease affects nearly every aspect of a person's life. That's true in the United States. It's a disease that heavily affects the American descendants of those who were forcibly brought here as slaves. I have not been called a slave in my lifetime, but in here, that's what we are. I think the one that was most visible and most impactful was the SNL skit that happened in 2023. So we get these gene therapies here. The CRISPR technology is first approved in humans ever. It is life-saving for society, and it happened in sickle cell. And the writers for SNL thought it'd be fun to make a skit. And essentially it was called the Yankee skit. I don't encourage you to watch it, but what it said was that people with sickle cell were dumb. It said that we would choose this Yankee Santa over this life-saving treatment, and then it also made the joke that only Black people had sickle cell and that the white colleague couldn't have sickle cell disease because they're not Black. We wrote our letters to SNL, we heard from a producer, they CC'd their chief diversity officer, said that they would look into it. But what was shameful about this is that we finally made it, and that all of these community voices worked overtime to get these therapies here, and none of that was captured in the mainstream press, and none of that was captured in some of these academic reports. So what I hope to do today is really capture the community voice and show that as a group of individuals, we really can make change with these stories that truly, truly reflect on how we live every day. Now this is Gabriella, she lives with sickle cell disease and she's from Houston, and she said what gives her hope is that right now, I was hearing was the stem cell. You don't have to use someone else's or be qualified or tested. You use your own stem cells, so that's wonderful news. That means that there's more opportunity out there to get cured from sickle cell. This was 2019, and what she was describing was gene therapy. So let's look at a little bit of drug development. And I wanted to share that background so you understand how long it's been and how overdue it is for us to have drug development in sickle cell disease. So the very first drug to be approved was hydroxyurea in 1998. And hydroxyurea is actually a chemotherapy drug, and it found that it just so happened to raise something called fetal hemoglobin in people living with sickle cell disease. So we all make fetal hemoglobin when we're babies, and when you hit about month 6, that fetal hemoglobin turns into adult hemoglobin. So the fetal hemoglobin, or the baby blood, it doesn't sickle. So for people with sickle cell disease, this was a big advancement for tools to work with the disease. Now, the next major advancement was the Baby Hug pediatric trial, and this is probably one of the most unsung stories in sickle cell disease. So this was a pediatric clinical trial where they put infants on hydroxyurea. This was a 9-year study with over a 90% retention rate for those participants. And you have to understand, the clinical trial started at 9 months old. So they were giving 9-month-old infants an experimental cancer drug. And it enrolled. It enrolled at almost 100%, and 90% of them stayed. When I spoke with one of the participants, because I was able to work on this trial, I asked her why she stayed, and she said it's because she trusted her nurse, Miss Brenda. And that's health equity. They were able to approach these patients, talk to the families, make them comfortable, and they found a nurse that looked like them, spoke like them, was from a background like them, and they trusted her, and they enrolled in these trials. And Brenda had her story featured in the NHLBI Today's Faces of Sickle Cell Disease. I submitted it. A next major milestone for us in the sickle cell disease community was the 2014 FDA Patient-Focused Drug Development meeting. So this meeting was part of a series that focused on rare disease and other underserved populations, and sickle cell was placed right before an ultra-rare condition, and the meeting happened in February. Why the season matters is because sickle cell disease is sensitive to the weather. So when it's really cold outside, more people experience a lot of pain, and they'll often go into crisis. My brother, for example, he probably should have been hospitalized, but he discharged himself, he didn't go into the hospital, he worked with his doctor, and he got here because this meeting was so important. So, yep. So the community showed up for force, and this was the first time we were able to tell FDA what patients needed, what the sickle cell disease community needed to change. The final report captures major complications from sickle cell disease, it captures health impacts of the condition, and what clinical outputs should be measured for clinical trials. And truthfully, our lives changed after this meeting and haven't been the same since. And this is a 10-year anniversary of this meeting, and so much has happened since then. So after this meeting came the Indari approval. So May 24, 2017 was the Oncological Drug Advisory Committee meeting, and they voted 10-3 to approve Indari. And Indari was the very first sickle cell disease specific clinical trial and the very first sickle cell disease specific treatment to come to market. Yes, and we did testify here, and the story behind this one is May 24th is also my birthday, so I did have to push my Miami trip a day, but that's okay. That's okay. The next major approvals were Oxbryta and Adakveo, and these came in 2019. And there wasn't an advisory committee for these meetings, but the companies did a fairly good job of making sure that the patients knew about these treatments. They knew about the clinical trials. But those in the community know that when you have new treatments that happen and treatments that are more expensive than the status quo, that then triggers something called an ICER review. And so how an ICER review got triggered for sickle cell is that hydroxyurea was being used off-label for a while. So off-label means that there's one indication for the drug, but you're using it for another because it's shown as beneficial. It was already generic by the time it reached the sickle cell disease community, so it costs about $50 a month to use. This next set of drugs were about $15,000 a month to use, and those two, Oxbryta and Adakveo, came out to be $80,000 to $100,000 a year, covered by insurance. But if you remember the economic burden that I showed you, that's a drop in the bucket compared to what it costs to take care of someone with sickle cell disease without. All of that is to say that this triggers something called an ICER review. So ICER stands for the Institute for Clinical and Economic Review, and they're a standalone nonprofit, and they call themselves the pricing watchdogs. And what they do is they use a form of health economics called clinical effectiveness. So essentially they're measuring, is it cheaper to pay for the drug or is it cheaper to pay for the person without it? And then I do want to emphasize that this organization is not regulated, and they definitely make up their own systems. And why it is important, or why their ICER reviews matter, is because these reports are often picked up by payers. And so across Medicaid programs and other decision committees, they use value assessments and value assessment frameworks to decide where to put treatments on formularies. And we know this because we've worked with enough state Medicaid formulary committees and have spoken with enough payers to know that, in fact, the ICER reviews were being used. So given all of that background, us at Sick Cells, we understood that the stigma surrounding sickle cell disease, engaging with an institution like this was vital in telling an accurate sickle cell disease story and ensuring that access to the long-awaited new treatments coming to market happened. So what we did next was, by March 2020, to engage with this ICER review, we had hosted a 4-part webinar series. We did in-person trainings. We helped the community submit and write over 92 comment letters. We conducted and fielded a survey. We hosted storytelling campaigns. We met with ICER bi-weekly. We contracted health economists, and we did all of this with the community voice in mind. And what we were able to see was that by the time we got to the most recent ICER review for the gene therapy, is that groundwork had really made it out to the payer communities. And we had payers reaching out to us directly to be connected to patient stories. And it also set us up to work directly with CMS and the Centers of Medicaid and Medicare Innovation so that we can make sure that these cell and gene therapy models are reflective of what's needed for the community. And then I put this. And I leave this picture here because we do all of this with the person centered. People with sickle cell, we make sure that their voices are centered. There we go. So all of that is leading up to policy and advancements, because we couldn't do any of this without policy. Part of our mission is elevating the voices of the sickle cell disease community, but then what we say is, while we're changing hearts and minds with the stories, we have to change policy so that we can protect those individuals living with sickle cell and ensure that they receive the best quality of care. So taking us through a little history lesson, the first ever sickle cell disease legislation that Congress passed was the National Sickle Cell Anemia Control Act of 1972. This was passed under the Nixon administration, and this was a landmark legislation for the community, as it authorized the first type of funding for education, trait testing, awareness, and more. Another major milestone in advocacy for sickle cell disease was Rare Disease Week 2018. This was one of the largest showing of sickle cell advocates coming to Rare Disease Week. One of my board members now, but at the time we took off a few days of work and we just called every single person we knew in sickle cell disease. One of those people was Kevin Wake. But what I like to show in this picture is we say that this was our first unofficial policy forum. I'm there sat on the ground, on the steps of the Reagan building, shouting out words from the act of legislation that was in Congress in that moment. But from this Rare Disease Week, it really ignited our efforts in advocacy in the sickle cell disease space. Shortly after that Rare Disease Week, the Sickle Cell Disease Treatment Act, as we call it, was signed into law, and this for this year was the only disease-specific legislation to be signed into law. And to make this happen, we built a coalition within the sickle cell disease space. We sent over 200 letters, we launched social media campaigns, we made direct phone calls, and we connected many individuals with their legislators. And a direct result of that legislation was that for the first time in our history, sickle cell programs were funded through Congress and not foundations, and we were able to expand the dollars. So for the first time in 2020, the CDC data collection program received funding. And so what that means is right now the program is expanded to 16 states. Just 4 years ago, there was only in 2 states, and it was funded through the foundation. And the HRSA programs also received increased funding, and they have been receiving increased funding since 2020. And now, because of that increased funding, there's dollars available to the community. So there's something called the HRSA follow-up program, and the follow-up program puts dollars directly into community-based organizations to do things like trait testing and education into the community. Another major milestone was under the previous administration was the previous Assistant Secretary of Health, Dr. Brett Gerard. He was a champion for sickle cell disease and changed our lives. He spearheaded the creation of the Mason Report and the blueprint addressing sickle cell disease. He hosted something called the Sickle Plus Initiative, and he also was part of releasing the first ever sickle cell disease report card and bringing these disparities to these major decision makers, which has many of us brought us here today. He also got us an invite to the White House with First Lady Melania Trump, and this was September of 2020. So it was a very interesting experience because this was at the peak of COVID, but having him there, this goes back to trust. He got us there, we trusted him, he told us it'd be okay, and it was a very important meeting for many of us. We've also had several policy forums, and so we've been able to meet with hundreds of legislators and staffers and people that really are excited to learn about sickle cell and just didn't know the disparity, and they want to make a difference when they learn about it. And so that brings us to the moment we've all been waiting for, these gene therapies. And so this is a picture of Joe. Joe was on the CRISPR trial, and he said, when I realized I would not have to live through constant pain and fatigue, choosing to undergo a gene therapy made it all worth it. So on Valentine's Day of 2023, there was an executive order released on drug pricing, and the order was to look at sickle cell and pediatric leukemia and figure out how to have Medicaid pay for gene therapies. We know that the gene therapies are going to be priced in the millions, and the concern was that if all of these people went to undergo gene therapy at the same time, how would the system afford it? And so with much research and community engagement and working with these agencies, there's now been released a model to try to demonstrate how to get the system to pay for these gene therapies. But before we get to the model, the approvals happened. So this was all caused by these approvals that Kevin had talked about, Lyfgenia and Casgevy. And Casgevy was the very first CRISPR technology to be approved in humans, and so it did require an advisory committee on Halloween. They love giving us important holidays. So leading up to this advisory committee, Six Cells hosted 3 informational education sessions. We also recruited community members and prepped them to give written comments and oral comments. One of our staff members, Elodie, her husband also testified, and so, we love Evan. There were 31 comments submitted, and there was 13 presenters that testified at that meeting. And the key takeaway message was it's time. There were people on the trial, there were people on the Bluebird trial, and none of them were scared. All of them were confident in their choices, and they said we absolutely had to do this, and they showed up with altruism so that they can benefit the broader sickle cell disease community. It also triggered a second ICER review, and you'll see there's a lot less engagement with this ICER review because there was so much work done in the first ICER review. And so we hosted 2 community calls. We co-hosted 2 focus groups with ICER, and the reason was because we wanted to put the people who were actually on the trials in front of this group so that there was no confusion about how they felt and what it took to get them onto these trials. We met with ICER 4 times, we submitted public comments, and then we prepped advocates for the public meeting. Now, I think more importantly, there was a lot of engagement this time around with Medicaid, because we know Medicaid is primary payer for many rare diseases and for sickle cell disease as well. So we met with CMMI. They're responsible for the cell and gene therapy model. We met with them 4 times between last year and this year. We submitted domains to consider for the cell and gene therapy model, and we provided written feedback. So the domain piece is very important. So the way that the models will work now is that CMMI will release an RFP, so a request for funding. Now, some of that funding will cover ancillary services. Ancillary services are like transportation and childcare, fertility preservation, et cetera. In order for the state Medicaid to issue those ancillary services, pieces of this money will go to community-based organizations as contractors, and the CBOs will be the ones paying for those ancillary services. Now, data on how much money community-based organizations spend on direct services, it's nowhere to be found, because many of the CBOs are focused on administering the services. They're not focused on publishing how much money they're spending on the services. So this is where I think the government really is getting this right. They trusted us. I said, hey, I know enough CBOs. Do you trust us to just have them pull reports from QuickBooks and give them over to you, just so you have a snapshot of how much money these organizations are spending? And they said yes. So in 2 weeks' time or so, we covered these various domains, and we worked with 3 community-based organizations. So the Sickle Cell Foundation of Georgia, the Sickle Cell Thalassemia Patient Network in New York, and the Cayenne Wellness Center in California. They submitted 5 years worth of data on how much they're spending. And that's me in New York, because I was standing over Ginger being like, Ginger, just turn to page 5. I think we got it. I think you got it. but the highest of patient assistance funds that they were paying out was for medication and co-pays, food and housing emergencies, and support groups and programs. Another major event was a listening session with CMS that happened on November 8th. So CMS released a sickle cell disease action plan, and Sickle Cells left comments for that plan. We also referred 10 CBOs, community-based organizations, to a listening session, and we hosted prep calls. Why this was important is because the sickle cell disease community has never spoken to Medicaid before. So this was one of those bridges where Medicaid seemed quite surprised of some of those realities, but what we said was, that's okay. You don't really know about someone until you have to pay for them. You've been paying for us for a long time. And so we're hoping through efforts like these, they'll be able to open up some of the access and reduce some of those barriers so that people with sickle cell disease can just have a little bit easier of a life. So this brings us back to the gene therapies. These are 3 more participants who have undergone curative therapies. We have Jimmy, we have Tisha, and we have Genesis. And all 3 of them have been just so positive and willing to share their stories over and over and over and over again, because they understand, and they've said this to me, that if telling their stories is going to inspire someone else or help someone else find their doctor or change the mind of a provider so that they write a prescription for a gene therapy, then they absolutely will do that. And that's the altruism that exists in the rare space. That's the altruism that I saw in Jen during our very first Rare Disease Week. And that's the altruism which ultimately brings us all here today, is to take care of ours, take care of our community. And so the final step here, and well, not the final, one of the last steps, most recent right here, is that the cell and gene therapy access models are here, they're live. And the models will be available in 2025, and this year right now, it's up to states to apply for the models. And so Sickle Cells already is reaching out to state Medicaid directors, we're connecting them to their community-based organizations, and we're trying to be that resource to help them understand that this is going to help all of us if they apply for these models and get this right with sickle cell disease. So our call to action here, that's Kevin, he's on the right, is we have 3 main call to actions. The first is that if there's any staffers or legislators in here, please contact your state Medicaid and encourage them to participate in the cell and gene therapy model. I keep saying this, sickle cell is the first, but when we get this right with sickle cell, it's going to benefit everyone in the rare disease space, anyone that comes from an underserved population, any minority population. It will ultimately make society better. The LOIs are due April 1st. Next, we have 2 pieces of sickle cell legislation in Congress right now, and so we're calling the Sickle Cell Disease Treatment Act of 2023 the HRSA reauthorization. So this is a reauthorization of that bill that I spoke about earlier, and then there's also the Comprehensive Care Act that is here to try to increase some of the benefits under Medicaid. And so the last slide here is just a reminder that we are people. All of these titles and Kevin gave me, fine, but the reality is we're just people. We're just the Valentines. We're the Valentines from a suburb that had no idea what sickle cell was until Marcus was born with sickle cell disease. And quite literally, I'm just Marcus's little sister. So I want to share with you something that Marcus said to me. He said, we need to remember that we all have power within us to make change. Our community joined together and worked to make moves towards a better future for all of us and to honor those that we've lost on the way. We're just getting started. With that, I want to say thank you.
I don't know how to follow that, but you know, Ashley, you summarize exactly what I feel every time I come up here, and I love Rare Disease Week, and that is the power of the patient. We can make huge, huge differences, and you just went through that whole story, and I love that. Can you share a little bit more about the current legislation that you touched on in your call of action, and how will that play into the access issues that the community faces?
Yeah. Sure, thank you so much for that. I'll talk about the HRSA reauthorization because I think that one is the furthest along. So that bill is a reauthorization to continue funding for that HRSA program and the CDC program. And why the HRSA program is also so important is that those dollars, as they increase, are able to capture more people with sickle cell and offer more education, and then get more dollars into the community-based organization. So that legislation, for all intents and purposes, has already been tied up with a bow. It's gone through committee last year. I think it might be on the calendar for voting, but I just want to speak more about that one because that one's really important to make sure that our programs keep growing.
Great. So let's talk a little bit about hydroxyurea. You touched on it. This was, as you said, approved over 25 years ago, yet the utilization in our community remains low. Can you share your personal thoughts on access, the newer therapies, as it relates to hydroxyurea and where we are with that product?
Sure. So when I think about hydroxyurea, I think of the word noncompliance because that word is used as almost derogatory when talking about people with sickle cell and hydroxyurea. And so what I mean by that is reports are coming out right now that hydroxyurea is underutilized, but some of that is not by accident. So for instance, my brother passed away in 2020 and he was on hydroxyurea for majority of his life, his adult life. It's just one drug, and it's a good drug for some people, but it doesn't work for everyone with sickle cell disease. In fact, there's different types of sickle cell disease. There's sickle cell SC, there's sickle cell beta thalassemia, and hydroxyurea is not actually prescribed for those types of sickle cell disease. But because it's the cheapest, severely the cheapest drug compared to the others, it's almost put in front of us as a barrier sometimes. So there's this disconnect between the patient community and the provider community and the insurance community about what hydroxyurea means. So sometimes when we're speaking with payers, we sort of put this in the case where you think you're saving money up front by requiring hydroxyurea as a step, but in the long run you're not, because it's still causing for all these complications and this disease progression. So it's actually more affordable to cover these oral compounds and the sorts before making someone or forcing someone to have to go on hydroxyurea.
Interesting. So you talked about the cell model or cell therapy model that is going to be available next year.
Yeah.
And you're encouraging states to, sign up for this now. Mm-hmm. We've had the cell and gene therapies approved in December. We've got states that are already starting to look at these for coverage. The model's not going to come out to next year. What can we do as a community now to advance gene therapy before that model is available for states to enroll in?
Yeah, that's a great question, and that's something that is a concern for the community. And this is where general rare disease legislation and the sorts really makes an effect. So the cell and gene therapies were approved under accelerated approval, which means they're required to be covered by Medicaid. And so I know, Kevin, you were at the Kansas DERB, and you had told me that, in fact, they will cover it. The prior auth matches the clinical trial, which is pretty open access, and then there's only about 5 people in Kansas who were qualified for the gene therapy anyways. So I think what it's looking like now is that the states will cover the gene therapies to an extent for the small minority population that will undergo them immediately. There will be access barriers. There's things like fertility preservation. That's not, if you're on Medicaid, that's not covered under Medicaid. I think it's only covered under Medicaid for sure in Illinois, but not in some of the other states. So there will be access barriers. Also, undergoing a gene therapy requires an entire care team. So they can only happen at FACT certified centers of excellences. So not many of those exist. So in Illinois, I'm from Illinois, we see people that are able to get gene therapies in Illinois, but we're seeing that folks from different states might have to cross into Illinois to get a gene therapy. And if you're on Medicaid, there isn't reciprocity between much of the states. So there will be challenges with access right now. I do think people with sickle cell, if they really want a gene therapy, we will find a way because there's so much visibility about this. And usually those who undergo gene therapy have a full care team that will work with them to make sure there's a way. But I think 2025 is going to be more positive in terms of access and the sorts. Yeah, so that's my reality view of access right now.
And I'll just say to the community, get involved, even if we don't have those models in place. We can make a difference. I did, as you said, went to the DUR meeting, and I was shocked. I was nervous going to the state. You know, in Kansas, not a whole lot of black people there. And so when you're looking at a therapy that primarily is for people of color in a very conservative state, you know, I was fearful. But that meeting, there was not one single negative comment or objection to covering gene therapy. I was shocked. I was probably the happiest person driving back home.
Yeah.
So, you know, get involved. Patients can make a difference.
Yeah, that's true.
So, well, thank you very much. I think that you have really painted a wonderful picture on how patients can help make a difference. And I have felt that for the past 6 years, every time I come up here on the Hill. And I think that today's meeting was so appropriate to have here because we are making a difference as patients and as a community. And I just encourage everyone to keep up the great work.
Great, thank you.
All right, a big thank you to Ashley and Kevin. That was an incredible, incredible conversation. Thank you. We can do all day, but Ashley and Kevin will be here following this, so feel free to approach them and they'll answer any questions you have. For today. Right after this, lunch will be served from 12 to 1. They are still on their way, so please be patient and use that time to socialize. If there are any panelists that stuck out to you today, feel free to approach them, have those conversations. That will be followed by the caucus briefing. That will be in this exact same room from 1 to 2:30. And then that will be followed by our group photo. So if you have your scarves with you, do not forget to wear those. It's going to be an excellent time. We're expecting a bit of rain, but hopefully we can manage around that. It's going to be a good time. And then we have our rare artist reception from 3:45 to 5:45 in the Russell Senate Office Building, room 325. I want to thank each and every one of you for being here today in person, joining us via live stream. We can put in the work to host these types of events, but without your presence, without your engagement, none of this is possible. So thank all of you for being here. And then one more special thank you to our sponsor, Alexion, Christina and Weston. I know you're here, but thank you for allowing this event to be possible. And again, thank you to our 2024 sponsors for making Rare Disease Week possible. So for that concludes our event. Thank you all for being here. Oh.
Just before we go, I just want to, I know we have our schedule, I'm going to go backwards, for the rest of today, and when we get to the caucus briefing, we're going to be joined by additional folks from the Hill, and hopefully you guys made a lot more friends yesterday, and thank you for all the work that you did to build our relationships on the Hill, and I suspect we'll have some press here for that as well. But I also want to let folks know, I know that our formal events hosted by EveryLife and RDLA will conclude later today and this evening, but I know people know that the mighty roar of this beautiful rare disease community, and Ashley told a really phenomenal story at the beginning of her presentation around the impact that the relationships that you make here have and serve as force multipliers for our individual communities and the work that that can do to serve our collective. And that mighty roar has made quite an imprint on our federal partners. And so many of you have probably been hearing that Congress saw fit to put a hearing on tomorrow morning to raise up many of the bills that many of us and our individual communities have been working on. So that is to the credit of this community for coming to Washington and saying, this week matters. And we're going to try and get some things moved this week. So that is to your credit. As we also know, NIH is hosting Rare Disease Day tomorrow, and we know FDA is hosting Rare Disease Day. But also tonight, for the very first time in history, the White House is hosting a rare disease forum that will be live streamed. And that is to the credit of this mighty community. And so we've been using the tagline that I think really reflects what we've been talking about here this morning, that we must not just understand and take the time to make space and appreciate our differences, but celebrate our differences and then come together unified, amplified, because we are stronger together. So thank you, everybody. And with that, I see them bringing lunch in, so just give them a minute to set it down on the tables, enjoy some lunch, fuel up, and then please join us back here for the caucus briefing at 1 o'clock.
One more note, if you have a reimbursement check and have not yet picked it up, you can go ahead and pick it up right side, outside of these doors at the table.